online documents and forms, more patients were able to be seen in a more timely manner. And again, I think that's just really indicative of some of the improvements that we could see here in Georgia, because it's not just rural and underserved areas, it's our healthcare centers. They need to be able to deploy their healthcare workforce more effectively and efficiently and meet needs of everybody across the spectrum, regardless of where they live or who their payer source is. But speaking of payer source, the next article is the Oliver study. The Oliver study looked at practice environments that required physician supervision, either as a collaborative agreement or direct supervision, and states where licensure did not require physician involvement. And they found that in those states that had full practice authority, there were lower hospitalizations, lower readmissions, and overall better healthcare outcomes for individuals who had care funded by Medicare and Medicaid. On the flip side of this issue, we are now finding that there are studies that are indicating there are costs associated with unnecessary supervision. So states are not only likely to see cost savings and better utilization by retiring outdated physician oversight, but actually by maintaining that, states could be causing more money to be spent on healthcare that needs to be done. The Kleiner article took a look again at states that allowed full practice authority and states that had a form of restriction. And they found that in states that had a form of restriction, well child care costs were 13 to 16% higher. There was no quality improvement. They saw across the board costs were higher in states that had more restriction on licensure. Additionally, we are seeing that states are doing more in-depth review of the cost of licensure. States like Florida and Massachusetts have had their own legislative bodies or an entity like RAND come in and do a review. Those states have found hundreds of millions of dollars in savings to the state in Medicaid, employee health, and work comp if they remove those unnecessary physician supervision barriers on advanced practice nursing license. In addition to the cost on the healthcare system, on patients, and state insurance payers, there's actually a direct cost to the state with this hyper-regulation of nursing practice. This last year, South Dakota introduced legislation for full practice authority for nurse practitioners. In South Dakota, nurse practitioners, similar to Georgia, had part of their license overseen by the Board of Nursing and the Board of Medicine, and the South Dakota Legislative Research Council, on a fiscal note, found that the state would save $80,000 every year simply by retiring those unnecessary physician supervision requirements. I'd like to point out that the supervision requirements that existed in South Dakota were not as onerous or as cumbersome or require as much documentation as the ones here in Georgia do. I don't know what that would correlate with cost, but I just want to have you keep that in mind. And then on the access issue, this is really the question of, if we change it, will they come? And I have to tell you that decades of workforce data tracking says that yes, they will come to your state if you make it a more attractive place to be. Nearly 24 years ago, the New England Journal of Medicine reported that favorable practice environments, AKA states that had right-sized licensure laws, had higher numbers of nurse practitioners and physician assistants in the state. In 2012, the University of Washington Rural Health Research Center found that that trend was continuing to hold true, and the authors of that paper recommended that states adopt favorable licensure laws as a strategy to attract APRNs to rural and underserved communities. And just to make sure that this hasn't become a timed out trend, last year Zhu and Associates reported similar findings of increased numbers of nurse practitioners in states with full practice authority and an increased number of services to rural and underserved populations. To drill down and give you a couple of examples of select states, Arizona. The Arizona AHEC did a workforce study that coincidentally timed with the 5-year mark from when that state adopted full practice authority. And AHEC found in that 5-year period of going from requiring an element of physician supervision to not, that state had an overall 52% increase in the number of nurse practitioners in the state. And of that 52%, 73% were in rural counties.
Can I ask you a question? Did any of these states implement or change their laws gradually so that you had full practice authority in the rural areas but not in the urbanized
The only state that I'm aware of that did that was in the 80s. And I would say that tracking workforce data incremental is likely not going to have you recruit more providers to get folks out. I read another piece of legislation in a state that was looking at this 2 years ago. And one of the things was if it was a rural, underserved, federally qualified county, nurse practitioners wouldn't have to have a collaborative agreement, which is a layer less onerous than what Georgia has right now. But if that county changed that designation, the PRN would then have to get into a relationship with a physician. And from a fiscal business, move your family, set up a business, open healthcare, to know that you could set up a successful practice and someone from a different discipline could see that that was effective and come in, and you would have to get a relationship or close your business, just was not something that nurse practitioners were willing to take on. It'd be sort of like saying, hey, we can let you open a Kroger grocery store in this particular area, but if Safeway comes in 6 months or a year from now, you have to have a relationship with Safeway to keep open.
That. If you, I mean, the rural areas are the population is shrinking. It's not going to grow. So you wouldn't all of a sudden come out. We've only got one county in the state, I think, that is really dramatically growing, and that's Lee County. That's dramatically changing. So they're all shrinking. So the market would stay the same, and the designation would stay the same.
The only place that I can say I can say for sure that a state has done that was in the 80s. I don't know that in 2017.
Is it still in practice?
No, that state now is full practice authority. Every location, every setting.
Did it gradually go through that cycle?
Only as a pilot it did.
What state was that?
The state of Oregon. And they've had full practice authority, for several decades now. That I think if you talked to individuals in those states, and I understand the political realities of how do we make a compromise, and we've seen that in other states, but the literature really is saying, especially the Oliver article and others.
If we give full practice